Tuberculosis. Introduction. Tuberculosis is also known as a Koch disease. It's a communicable infection caused by members of the Mycobacterium tuberculosis complex, which include the Tuberculobacillus, Mycobacterium tuberculosis, Mycobacterium bovis, Mycobacterium africanum, Mycobacterium microti, Microbacterium canneti, Mycobacterium caprae, Mycobacterium pinnipedii, and Mycobacterium origes. Mycobacterium tuberculosis causes tuberculosis and is a leading infectious cause of death in adults worldwide. Mycobacterium tuberculosis. Spread of infection is via aerosol droplet nuclei. Reservoir is predominantly humans. Mycobacterium bovis. Mode of transmission, predominantly via ingestion of contaminated cow's milk. Reservoir is predominantly cattle. It causes gastrointestinal tuberculosis in humans. Mycobacterium africanum. It's the common cause of tuberculosis in West, Central, and East Africa. Mycobacterium microti. A mycobacterial species of the Mycobacterium tuberculosis complex that can cause tuberculosis in animals, especially wild rodents. It's a rare cause of infections in humans. Manifestations include anorexia and malaise. Mycobacterium tuberculosis is 20% acid-fast bacilli, owing its acid fastness to mycolic acid. Virulence factors of Mycobacterium tuberculosis are cord factor, lipoarabinomannan. It helps in attachment and can be detected in urine. Heat shock protein cord factor. These factors aid in its virulence by preventing phagolysosomal fusion and helps Mycobacterium tuberculosis to produce granulomatous reactions. Risk factors for tuberculosis may be divided as follows: impaired immunity, host factors, increased exposure to infectious persons, environmental factors. Microbiology. Cell envelope. The cell envelope is a distinguishing feature of the organisms belonging to the genus Mycobacterium. The mycobacterial cell envelope is composed of a core of 3 macromolecules, covalently linked to each other: peptidoglycan, arabinogalactan, and mycolic acids, and a polysaccharide, lipoarabinomannan, which is thought to be anchored to the plasma membrane. The outermost layer, the mycobacterial outer membrane, consists of a lipid bilayer structure. Mycolic acid, a beta-hydroxy fatty acid, is the major constituent of the cell envelope, accounting for more than 50% by weight. This structure defines the genus. Glycolipids are attached to the outside of the envelope layer through a connection to the mycolic acid layer. Proteins are also embedded in this cell wall complex. Glycolipid components are implicated in cord formation, whereby tuberculosis bacilli clump together, forming a serpiginous structure seen on microscopy. Staining characteristics. The cell wall components give Mycobacterium its characteristic staining properties. The organism stains positive with Gram stain. The mycolic acid structure confers the ability to resist destaining by acid alcohol after being stained by certain aniline dyes, leading to the term acid-fast bacillus. Microscopy to detect acid-fast bacillus, using Ziehl-Neelsen or Kenyon stain, is the most commonly used procedure to diagnose tuberculosis in the world, especially in countries with limited laboratory capacity. Microscopy of specimens stained with a fluorochrome dye, such as Oramine O, provides an easier, more efficient, and approximately a 10-fold more sensitive alternative. However, microscopic detection of mycobacteria does not distinguish Mycobacterium tuberculosis from non-tuberculosis mycobacteria. Pathogenesis. This organism gains entry via inhalation of infected droplets into the respiratory tract, where they reside in alveolar macrophages and replicate inside. Lipoarabinomannan on mycobacterial surface binds to complement receptors and mannose receptors, because of which internalization of bacilli happens. Phagolysomal fusion is prevented by lipoarabinomannan and cord factor, which increases survival inside the macrophages. When a macrophage ruptures, it releases bacillary content, which infects other phagocytes. This marks the first phase of infection, in which there is a bacterial proliferation and no mild symptoms of a general flu-like illness. Approximately after 3 weeks of exposure, cell-mediated immunity develops, and CD4 cells release interferon gamma, which activates macrophages, which in turn mediates the release of tumor necrosis factor, nitric oxide, etc. By complex outplay of immunity, a granulomatous reaction occurs with tissue damage, forming a caseous granuloma and causing cessation of the spread of the organism. All this will happen if the immunity of the patient is good, but if any part of cell-mediated immunity is not working efficiently, it leads to very serious disease and even fatal outcomes. Types. Tuberculosis is of two types, primary and secondary. Primary tuberculosis. Primary tuberculosis is a term that describes new tuberculosis infection or active disease in a previously naive host. It occurs most commonly in children, and most commonly involves lungs with unilateral hilar lymph node enlargement. It usually starts as a latent disease. In primary tuberculosis, other than pulmonary features, some systemic manifestations are seen as well: phyllotinular, keratoconjunctivitis, erythema nodosum, pleural effusion, etc. In the lungs, notably, Gons foci are formed in the lower part of the upper lobe. It is caseous necrosis containing epithelioid histiocytes and multinucleate giant cells. When this subpleural foci involves regional lymph node, it's called Gons complex. When this Gons complex undergoes calcification and fibrosis, it forms Ranks complex that can be viewed on radiographs. The tuberculosis nodule in the lung apex formed due to the dissemination of primary tuberculosis from another organ to the lungs is known as Simon's focus. Chest radiograph. In primary pulmonary tuberculosis, the chest radiograph is often normal. Common radiographic changes include hilar and/or mediastinal lymphadenopathy, pulmonary consolidation, and pleural effusion. Hilar lymphadenopathy is the most common finding and occurs in 65% of cases. Hilar changes are visible early as 1 week after skin test conversion and within 2 months in all cases. The consolidation in primary tuberculosis may be segmental or lobar, may involve any lobe, and is typically homogeneous. Pulmonary consolidation will be seen in approximately 27% of patients. In general, it's resolved slowly over months to 10 years. Pleural effusions develop in approximately 1/3 of patients, typically within the first 3 to 4 months after infection, but occasionally as late as 1 year. Secondary tuberculosis, post-primary tuberculosis. It occurs post-primary infection and may occur immediately following a primary exposure or years after initial infection. Since reactivation tuberculosis is the most common form of the disease, bacterial factors associated with latency and transition from latency to active disease are important virulence factors. Reactivation of latent primary infection is mostly due to a fall in the immunity of the host. It's commonly seen in adults and affects one or both lung apices. Initially, small 1 to 2 centimeters cavity is seen in the apical pleura, which is circumscribed. With progressive pulmonary tuberculosis, this cavity expands, producing large cavitary lesions inside the lungs. If immunosuppression of the host is severe, such cavities with high bacterial load can undergo dissemination, and the organism can intrude into vascular channels or lymphatics. And this recirculation of organism inside the lungs leads to miliary tuberculosis. Note: the most common vessel to be eroded by a tubercular cavity is the bronchial artery. Furthermore, the heterogeneous spread can occur as well, and Mycobacterium tuberculosis can infect other organ systems throughout the body, leading to extrapulmonary forms of tuberculosis, like lymph nodes, lymphadenitis, kidneys, renal tuberculosis, brain, tubercular meningitis, heart, tubercular pericarditis, epididymis, fallopian tube, gastrointestinal tuberculosis, in which most common site is ileocecal junction, etc. Extrapulmonary tuberculosis involves lymph nodes more commonly than pleura, and pleura is more common than the genital urinary tract. Lymph node is greater than pleura, and pleura is greater than genital urinary tract. Note: miliary tuberculosis is the widespread dissemination of Mycobacterium tuberculosis via heterogeneous spread, that is, by blood. Fever. It's usually low-grade at the onset, but becomes marked with the progression of the disease. It's classically diurnal, with an afebrile period early in the morning and a gradual rising temperature throughout the day, reaching a peak in the late afternoon or evening. Fever subsides during sleep, but night sweats may occur. Fever and night sweats are more common among patients with advanced pulmonary tuberculosis. Cough. Cough may be absent or mild initially and may be non-productive or productive of only scant sputum. Initially, it may present only in the morning, when accumulated secretions during sleep are expectorated. As the disease progresses, cough becomes more continuous throughout the day and productive of yellow or yellow-green and occasionally blood-streaked sputum, which is rarely foul-smelling. Symptomatic individuals are more likely to have smear-positive sputum. Frank hemoptysis, due to caseous sloughing or endobronchial erosion, typically occurs later in the disease and is rarely massive. Nocturnal coughing is associated with advanced disease, often with cavitation. Dyspnea. Dyspnea can occur in the setting of extensive parenchymal involvement, pleural effusions, or a pneumothorax. Pleuritic chest pain is not common, but when present, signifies inflammation, abutting or invading the pleura, with or without an effusion. Rarely, this can progress to frank empyema. In the absence of treatment, patients may present with painful ulcers of the mouth, tongue, larynx, or gastrointestinal tract due to chronic expectoration and swallowing of highly infectious secretions. These findings are rare in the setting of anti-tuberculous therapy. Radiographic findings. Post-primary tuberculosis typically involves the apical and posterior segments of the upper lobes, 80 to 90% of patients. The most common and typical manifestation consists of patchy areas of consolidation with poorly defined margins. Computed tomography scanning is more sensitive than chest radiography for diagnosis, particularly for smaller lesions located in the apex of the lung. Computed tomography scans typically demonstrate more lesions than are visible on chest radiographs and are particularly helpful in detecting hilar or mediastinal lymphadenopathy. Lower lung tuberculosis. In post-primary tuberculosis, the upper lobes are the most common site of disease. Sometimes only the lower lobes are affected. This can lead to misdiagnosis as viral or bacterial pneumonia, bronchiectasis, or carcinoma. Complications. Pulmonary complications of tuberculosis include hemoptysis, pneumothorax, bronchiectasis, extensive pulmonary destruction, including pulmonary gangrene, fistula, tracheobronchial stenosis, malignancy, and chronic pulmonary aspergillosis. These complications occur more commonly in the setting of post-primary disease. Physical findings. Physical findings of pulmonary tuberculosis are not specific and usually are absent in mild or moderate disease. Dullness with decreased firmitis may indicate pleural thickening or effusion. Crackles may be present throughout inspiration or may be heard only after a short cough. Post-tussive crackles. When large areas of the lung are involved, signs of consolidation associated with open bronchi, such as whispered pectoriloquy and tubular breath sounds, may be heard. Distant hollow breath sounds over cavities are called amphoric, after the sound made by blowing across the mouth of jars used in antiquity. Extrapulmonary signs include clubbing and findings localized to other sites of involvement. Note: tuberculosis is the most common cause of hemoptysis in India and the United States of America. If hemoptysis is massively greater than 600 milliliters per day, it's treated by bronchial artery embolization. Extra edge. Lesions of secondary tuberculosis. Apical and supraclavicular lesion of pulmonary tuberculosis is known as Pull's lesion. Infraclavicular lesion of pulmonary tuberculosis is known as Asman's focus. With miliary tuberculosis, small foci are seen throughout the body. Some specific foci are as below. Rich's focus. Tuberculosis granuloma in the brain cortex. Wiegert's foci. Tuberculosis foci in the pulmonary vein. Simmons foci. Tuberculosis foci in the liver. Extrapulmonary tuberculosis. Tabes mesenterica, abdominal tuberculosis. Pot spine, tuberculosis spondylitis. Lupus vulgaris, the most common form of cutaneous tuberculosis. Congenital tuberculosis. It's a variant of tuberculosis in which the fetus is affected either intrauterine or during the passage via the birth canal. Infection can occur in the fetus hematogeneously, via the umbilical vein, due to aspiration of infected amniotic fluid or ingestion of amniotic fluid. Liver is the most common site involved in congenital tuberculosis. Diagnosis of congenital tuberculosis is established using Cantwell revised criteria. Here's a table of revised diagnostic criteria for congenital tuberculosis. Prove tuberculosis lesions in the infants plus at least one of the following. 1. Lesions in the first week of life. 2. A primary hepatic complex of caseating hepatic granulomas. 3. Tuberculosis infection of the placenta or the maternal genital tract. 4. Exclusion of the possibility of postnatal transmission by a thorough investigation of contacts, including the infant's hospital attendants, and by adherence to existing recommendations for treating infants exposed to tuberculosis. Endobronchial tuberculosis. Introduction. Endobronchial tuberculosis is defined as a tuberculosis disease that involves the tracheobronchial tree. It may develop via a direct extension to the bronchi from an adjacent parenchymal focus, usually a cavity, or via the spread of organisms to the bronchi via infected sputum. Lesions are more likely to be observed in the main and upper bronchi. Symptoms. Symptoms include a productive cough, chest pain, hemoptysis, lethargy, fever, and dyspnea. Symptoms may be acute in onset and be confused with bacterial pneumonia, asthma, or foreign body aspiration. The clinical manifestations can also be subacute or chronic, resembling bronchogenic carcinoma. A barking cough is seen in approximately 2/3 of patients with the endobronchial disease, often accompanied by sputum production. Rarely do patients develop so-called bronchuria, which is the production of more than 500 milliliters per day of sputum. Wheezing and hemoptysis may also be observed. Lymph node rupture can be associated with chest pain. The presence of dyspnea may signal obstruction or atelectasis. Physical findings. Physical findings can include diminished breath sounds, rhonchi, or wheezing. The wheeze typically is low-pitched, monophonic, constant, and is oscillated consistently over the same area on the chest wall. Radiographic findings. The most common radiographic finding of the endobronchial spread of tuberculosis in adults is upper lobe consolidation and cavity with ipsilateral spread to the lower lobe, and less commonly, contralateral lung. On high-resolution computed tomography, endobronchial spread of pulmonary TB, typically manifested by central lobular nodules, is seen in 95 to 97% of patients. Another common manifestation of endobronchial spread on computed tomography is the presence of branching linear structures originating from a single stalk, with associated small centrolobular nodular opacities, the tree and bud appearance. Bronchoscopy. Findings on bronchoscopy may include edematous hyperemic lesions with or without ulceration or fibrosis, or nonspecific bronchitis. Complications. Bronchial stenosis and stricture formation may develop in more than 2/3 of patients. Diagnosis. The diagnosis of pulmonary tuberculosis should be suspected in patients with relevant clinical manifestations: cough greater than 2 to 3 weeks duration, lymphadenopathy, fever, night sweats, weight loss, and relevant epidemiologic factors: history of prior tuberculosis infection or disease, known or possible tuberculosis exposure, and/or past or present residence in or travel to an area where tuberculosis is endemic. Establishing a diagnosis. The diagnosis of pulmonary tuberculosis is definitely established by isolation of Mycobacterium tuberculosis from a bodily secretion, for example, culture of sputum, bronchoalveolar lavage or pleural fluid, or tissue, pleural biopsy or lung biopsy. Additional diagnostic tools include sputum acid-fast bacilli smear and nucleic acid amplification testing. A positive nucleic acid amplification test, with or without acid-fast bacilli smear positivity, is considered sufficient for diagnosis of tuberculosis. Sputum examination. 2 sputum samples are taken. One is a spot sample, and the second sample is an early morning sample. Auramine-rhodamine staining. It's a type of fluorescent staining. It's usually done in cases of more bacterial load. The disadvantage of this staining is that false positive rates are high. The niacin, nitrate reductase, and catalase test are the 3 biochemical tests most frequently used to distinguish Mycobacterium tuberculosis from other mycobacterial species. Ziehl-Neelsen staining. It's also known as the acid-fast stain, which penetrates the waxy coat of the pathogen. The acid used in the staining process washes the carbonyl fusion stain out of the cell walls of non-acid-fast bacteria. The acid-fast bacteria retain it and stain red, pink. Lowenstein-Jensen media. Lowenstein-Jensen media is a green-colored media. It takes 6 to 8 weeks to culture, and eggs are used for solidification. The selective media agent is malachite green dye. For bacilli to be visible on culture media, 10 to 100 bacilli per millimeter sputum must be present. It shows rough, tough, buff colonies. Rough denotes the irregular, wrinkled appearance. Tough means it's difficult to remove. Buff denotes its yellowish-brown color. Molecular methods that aid in diagnosis are Mycobacterium tuberculosis polymerase chain reaction methods. It targets on IS6110 gene, and it gives rapid results as its turnaround time is 24 hours only. The disadvantage of polymerase chain reaction testing is that it does not differentiate between active and latent Mycobacterium tuberculosis polymerase chain reaction method. Gene experiment rifampicin. Rifampicin depicts detection of rifampicin resistance. Cartridge-based nucleic acid amplification test. Rifampicin drug resistance based on the beta subunit of RNA polymerase gene is also detected. Line probe assays. It's a polymerase chain reaction-based method in which multi-drug resistance is also detected. Quantiferon tuberculosis gold assay. Interferon gamma release assay. It's used for the detection of latent tuberculosis cases. Tuberculin Man-2 test. The Man-2 tuberculin skin test, formerly called the purified protein derivative skin test, is the standard method of determining whether a person is infected with Mycobacterium tuberculosis. It's performed by injecting purified protein derivative into the skin, usually the forearm. The skin reaction, which is a type 4 hypersensitivity reaction, is read 48 to 72 hours after injection, and it must produce a skin elevation of about 6 to 10 millimeters in diameter. An elevation of greater than or equal to 15 millimeters is considered positive in any person. If induration is less than 5 millimeters, the Man-2 test is negative. If induration is equal to 5 to 10 millimeters, the Man-2 test is equivocal. If induration is greater than 10 millimeters, the Man-2 test is positive. Man-2 test can be false positive in cases of recent BCG vaccination, atypical Mycobacteria infection. Man-2 test can be false negative in cases of HIV positive, advanced stage, familiary tuberculosis, malignancy, immunosuppression. Automated liquid culture media methods. This method uses liquid broth Middlebrook 7H9. This broth has oxygen-sensitive fluorescent compound, and the turnover time for this test is 8 to 14 days. Different types of this diagnostic method are BAC-TEC 460 tuberculosis, BACTEC Mycobacteria growth indicator tube, BACT alert. Drug-resistant TB. Drug-resistant tuberculosis should be suspected in the setting of relevant risk factors. These include a prior episode of tuberculosis treatment, progressive clinical and/or radiographic findings while on tuberculosis therapy, residence in or travel to a region with a high prevalence of drug-resistant tuberculosis, and/or exposure to an individual with known or suspected infectious drug-resistant tuberculosis. Definitive diagnosis of drug-resistant tuberculosis is established via laboratory identification of Mycobacterium tuberculosis in sputum or other clinical specimens, with drug susceptibility testing demonstrating resistance to one or more anti-tuberculous agents. Culture-based testing. Culture-based testing is the gold standard for diagnosis of drug-resistant tuberculosis. Extra edge. Pleural tuberculosis screening is done with adenosine deaminase levels. Investigation of choice for diagnosis of pleural tuberculosis is cartridge-based nucleic acid amplification test. Human amino and tuberculosis. HIV is an immunocompromised state, and when CD4 count less than 500, it becomes a likely condition for tuberculosis infection to occur. Such cases with both infections have a bad prognosis. There are some characteristic features of tuberculosis in an HIV-positive patient. Cavities are smaller, sputum is negative, mantle is false negative, and disseminated disease is very common. In such cases, treatment must include both anti-tubercular treatment and antiretroviral therapy, but it's important to note that one should start anti-tubercular treatment, and 2 weeks followed by that, antiretroviral therapy should be given to avoid immune reconstitution inflammatory syndrome. Tuberculosis. Now, we'll be discussing about treatment. First-line agents. First-line anti-tuberculous agents for treatment of susceptible tuberculosis consist of isoniazid, erythromycin, usually rifampin, ethambutol, pyrazinamide, and moxifloxacin when administered in combination with isoniazid, rifampicin, and pyrazinamide. These drugs have a different target on the mycobacterial cell, whether a cell wall component or at the DNA level. Most of the drugs must be orally absorbed, especially because they must be administered for 6 to 9 months, depending on their regimen. Note: the injectable drug, streptomycin, an aminoglycoside, has now been used more frequently because of the growing prevalence of resistance to the 4 oral drugs. Active tuberculosis infection. For active tuberculosis infection, the patient should receive 6 months or 9 months of treatment. The 6-monthly regimen consists of 2 months of rifampin, isoniazid, pyrazinamide, and ethambutol, the Wright protocol, followed by 4 months of using 2 or 3 drugs based on antibiotic susceptibilities. The 9-monthly regimen consists of isoniazid and rifampin. A tuberculosis isolate is known to be fully susceptible when it's susceptible to isoniazid and rifampin. Once a tuberculosis isolate is known to be fully susceptible, ethambutol or streptomycin can be discontinued, keeping rifampin and isoniazid. Treatment completion. Dual drug combinations, most common as isoniazid and rifampin, are most useful in the treatment completion of active infection, especially if the isolates are fully susceptible. These are also useful in latent tuberculosis infection. Prophylaxis. Prophylactic therapy as a means of preventing tuberculosis in people who test positive in the MAN2 test is particularly important, where exposure to someone with active tuberculosis can make an individual purified protein derivative skin test positive, especially after visiting countries where tuberculosis is prevalent. Isoniazid alone is often given for this prophylaxis. Second-line agents. Evidence of drug resistance, contraindications, or intolerance to first-line anti-tuberculous agents warrants use of second-line agents. Bedaquiline. Bedaquiline is an oral diarylquinolone drug with bactericidal anti-tuberculous activity approved by the United States Food and Drug Administration in 2012 for the treatment of multi-drug-resistant tuberculosis. Clofazimine. Clofazimine is a semi-synthetic ribinophenazine postulated to disrupt electron transport and generate reactive oxygen species. Cycloserine. Cycloserine disrupts peptidoglycan synthesis as a competitive inhibitor of alanine racemase and D-alanine ligase. Cycloserine may be associated with neuropsychiatric adverse reactions. Therefore, it should be used with caution in patients with pre-existing mental health issues. Delamanid. Delamanid is an oral nitrodihydroimidazole drug that inhibits mycolic acid synthesis. Ethionamide. Ethionamide may be used for the treatment of drug-resistant tuberculosis. Linezolid. Linezolid may be used for the treatment of multi-drug-resistant tuberculosis and extensively drug-resistant tuberculosis or in settings of intolerance to other drugs. Its use is often limited by adverse effects such as bone marrow suppression, neuropathy, gastrointestinal symptoms, and retinitis. Para-aminosalicylic acid. Para-aminosalicylic acid is bacteriostatic. It has limited efficacy for treatment of TB and is poorly tolerated due to GI and endocrine side effects, including hypothyroidism, particularly when administered in combination with ethionamide. Predimated. Predimated, a nitroimidazole, has bactericidal activity. A regimen of predimated, bedaquiline, and high-dose linezolid has Food and Drug Administration approval for treatment of patients with extensively drug-resistant tuberculosis or treatment-intolerant or non-responsive multi-drug-resistant tuberculosis. Drug resistance. 1. Primary transmitted drug resistance develops when infection is due to a drug-resistant strain. 2. Secondary acquired drug resistance develops when resistance occurs during or after treatment. 3. Monodrug resistance is resistance to one first-line drug. 4. Polydrug resistance is resistance to more than one first-line drug other than both isoniazid and rifampicin. 5. Multi-drug resistance is resistance to both isoniazid and rifampicin. 6. Extensively drug-resistant, multi-drug resistant, and resistance to fluoroquinolones and one of the injectables among second-line antituberculin treatment. 7. Total drug-resistant, extremely drug-resistant, resistance to all first- and second-line antituberculosis drugs. Resistance to drugs is due to gene mutations. Isoniazid resistance is due to gene mutations of inhibin subunit alpha, tuberculosis catalase peroxidase, alkyl hydroperoxide reductase C genes, and rifampicin resistance is due to beta subunit of bacterial RNA polymerase gene mutations. For multi-drug resistant tuberculosis, the following drugs can be used. Amikacin aminoglycoside is indicated for the treatment of tuberculosis suspected to be caused by streptomycin-resistant or multi-drug-resistant mycobacterial strains. However, this must be used in combination with other second-line drugs to avoid the emergence of resistance. Ciprofloxacin, fluoroquinolone, is often active against strains of Mycobacterium tuberculosis resistant to first-line agents. Ethionamide, since it's structurally similar to isoniazid, also interferes with mycolic acid synthesis. Cycloserine is a broad-spectrum antibiotic oral drug used in multi-drug-resistant tuberculosis treatment. Extensively drug-resistant tuberculosis is treated with capreomycin, cycloserine, clofazimine, ethionamide, ethambutol for 6 to 12 months, or pyrazinamide, bedaquiline, plus ethionamide, clofazimine, cyclosporine, linezolid, ethambutol for 18 months. Mycobacterium avium complex. As for atypical mycobacteria, treatment of Mycobacterium avium complex requires a combination of drugs most commonly azithromycin and rifabutin. Azithromycin has favored over clarithromycin because of cytochrome P450 interactions with rifabutin. Rifampin is an inducer of cytochrome P450, whereas clarithromycin is an inhibitor, so azithromycin is favored over clarithromycin. Rifabutin, which is in the same category as rifampin, inhibitors of RNA polymerase, is favored over rifampin in patients with HIV infection. That's all for today. We'll see you next time.